Well, welcome everybody. I'm Jeff. I'm a ThyCa facilitator out here in Los Angeles. We're very pleased today to have Dr. Erik Alexander and Dr. Julia Noel with us, talking about managing thyroid nodules. I'm going to quickly read their bios. Dr. Alexander is an endocrinologist at the Dana-Farber Cancer Institute in Boston. He has published over 150 peer-reviewed articles, mostly focused on the optimal evaluation of thyroid nodules and the prevention of unnecessary thyroid surgery. He's a member of the 2016 American Thyroid Association Guidelines Committee on the care of patients with thyroid nodules and thyroid cancer. And he was also co-chairman of a separate 2017 Guidelines Committee on the care of patients with thyroid disease during pregnancy. He's an active clinician caring for over 40 patients every week, and he also serves as a ThyCa medical advisor. Dr. Julia Noel is a head and neck surgeon at Stanford University Medical Center in Palo Alto, California. She specializes in surgery of the thyroid and parathyroid glands and lymph node dissections. She has additional expertise and interest in both advanced and recurrent thyroid cancer, minimally invasive approaches, and also ultrasound guided techniques in the office. So welcome to you both.
Thank you. And thank you to everyone who's joining us. It's an honor to be a part of the ThyCa conference this year and appreciate the virtual opportunity. And so the way we'll move forward with this session is we'll split the session. So you'll hear myself talk on indeterminate nodules, thyroid nodules for the first half, then I'll turn it over to Dr. Noel for the latter half to talk about her topic. And we'll take a little bit of question and answers after each one. So if you have some questions, feel free to put them in the Q&A box, and we may not be able to get to all of them, but we'll certainly do our best. And we'll do my questions kind of after my talk, and then we'll do Dr. Noel's questions after hers as well. So I'm going to go ahead and jump right into my topic. I'm going to talk for the next 20 minutes probably on thyroid nodules and molecular diagnostics. I'll walk you through what I think a patient should know as background, and I also will give you a little bit of insight into how doctors are thinking about your nodule. I will go into some of the science and some of the data. It will be a lot of numbers a little bit, but meant to just give you an idea of how we're thinking about it, not for you to memorize numbers or get into the details to that degree. And it's a pleasure to speak to you from Boston. What you should know to start is that I've been active in this space for a long time. I've been involved in scientific research. I've been consultants to companies. I do think this moves our field forward, but realize I've been in touch with these companies along the way. Here's what I'll try and talk about, a little bit of the past, the present, and the future. I want to tell you a little bit the background story, which many of you may know, but not all, about how we think about nodule evaluation. And then I really want to bring you up to speed as to how molecular analysis is used now in the clinics and why it's kind of moving us forward into the future. What should we be thinking about? How are we using it differently? So the starting point is this, which is kind of the standard approach to how a physician thinks about your nodule. Which you'll notice here at the title here is that we think about nodules clinically relevant when they're generally larger than 1 to 1.5 centimeters. And that's important. We know that smaller nodules, even if they appear to be abnormal, do not tend to pose a substantial risk to you. And so we think of clinical relevance generally as when nodules are greater than this size. When they are, based on the way they appear a little bit on ultrasound, the initial assessment is that ultrasound and a check of your thyroid function. That's TSH. And in a rare case, we find the TSH suppressed. That means there's too much thyroid hormone. And so that leads us down a path to make sure we're understanding on the bottom left if the nodule is functional. That would be a benign process. But you'll see most of the time, 95%, the care heads to the bottom right of this slide, which is going to be fine needle aspiration using ultrasound guidance. And one of the problems we run into here is the results that can come from that ultrasound guided FNA. So what we end up here with under the microscope is what we call cytology. And this is the normal breakdown of what the nodule biopsy would show. You'll notice in about 2/3 of cases, you get a benign reading. You get no malignant cells. That's the reason we do the biopsy, and it's so simple to do via aspiration, is that most of the time we get a benign, accurate result. So that really allows us then to take a more conservative approach. You'll note that about 5% of the time we get a true positive, so a diagnostic sample that is accurate for malignancy, often papillary carcinoma. But I draw your attention to the middle here, the 20 to 25% that are indeterminate. What that means is that we get these different categories: atypical, suspicious for a neoplasm, suspicious for malignancy. These are terms that we use inside our teams to communicate and express kind of layers of risk to each other. But it means that there's an abnormality that is noted, so it can't be called benign, but yet we don't know that it's malignant too. And so we really are uncertain, though the risk of cancer has gone up a little bit. Now, it used to be that the only way to know what to do was to remove these surgically, because then we would have kind of final answers, truth of whether it was cancer, benign or not. And that was a lot, however, of unnecessary surgery. And that's because that's shown on this slide. So at the Brigham, we just completed our analysis here in Boston of the last 20,000 consecutive nodules that were evaluated. And with this paradigm, what do we see? And what I'm showing on this slide is those indeterminate results, those categories that we talked about on the left here under FNA cytology. And when they were sent for surgery, the proportion that proved to be cancerous then as a final diagnosis. So the reason this is important is that when you look at these categories of indeterminate results, what you see is that most of them, many of them, proved to be benign. That was the problem that we've been trying to solve for the last decade, that we were sending a lot of people to surgery, what ultimately was for benign disease. So we hope that that can be prevented. Now, the reason we were doing that is we had no way to know which ones were cancer conclusively, and that can pose a risk. So there was a necessary process to try and figure out the diagnosis. But it's this background that led us to kind of this real paradigm shift in the last 10 years, which was that we have moved now from just moving forward with cytology to using synergistically molecular diagnostic tests. And that has led to a significant reduction in unnecessary surgery. And in fact, we apply these molecular tests only to these indeterminate readings, these so-called Bethesda 3 and 4 nodules. And in most cases now, it's kind of the active next step. Most guidelines are supportive of that. It has shown its ability to be cost effective. And while there are other options, we don't want to be universal in only one course of care. We want every individual patient to be looked at as their own patient, of course. We find that the other options, which can be used, often are still not the leading standard. We know that sometimes you can repeat the FNA at times, but there is variation in those readings, so it doesn't often solve a lot of problems. But I do want to emphasize there are times increasingly where we want to consider a conservative management, even with an indeterminate cytology. Some select patients may not need to move forward with surgery or molecular testing, especially if things appear stable or there's other illness going on that should take priority. But our topic here is to really talk a little bit more about the molecular diagnostic tests. And so to start that process, I like to begin with kind of this basic figure. This is how we think about cellular biology as a starting point. That in most cells in our body, there is DNA. That is then transcribed to RNA, and that is then translated into a protein. The protein does the job of the cell or the organ. And then we know there's this other category of microRNA molecules, and these are inhibitory to that last step. So there's 4 buckets of kind of cellular molecular material that we think about in terms of molecular understanding. And what's nice is that we've actually seen, and I'll show you here moving forward, tests that have been developed for the thyroid as it relates to indeterminate cytology in each of these categories. For example, as we think about proteins, the hypothesis early on was that certain cellular proteins were over or under expressed in association with malignant or benign disease. So you could stain it. You see the brown areas on these pictures. And that was then linking in with either a higher risk of malignant or a higher risk of benign processes. And the classic one we use in this field right now, which has been used a little bit more on histopathology, so after the specimen has been removed, is galectin-3. But this has been around for a while and felt not to be quite as quantitative as we needed. So I'll show you the other three categories. I mentioned microRNA molecules or tests based on this process. MicroRNAs are non-coding, what we call post-translational modifiers of gene expression, that last step. There's about 1,000 or so in the genome, and they do associate with malignant or benign disease. And so when we talk RNA, what we're looking for here is expression, how much RNA is expressed. And so companies have moved this forward to try and determine certain RNAs. Out of those 1,000, maybe you look at 3 or 30, you find a pattern. That pattern is then going to give you a signature. And some companies have taken this forward, most notably the Interpace product, which goes by a trade name Thyromere. And then I'm really going to focus so much of my time on the last two tests. I mentioned then a third bucket molecularly was RNA, and these are referred to as the gene sequencing or gene expression classifiers. It's not too different from what I just told you with microRNA, but here instead, the scientists have been able to look at all genes in your body, all the genes that we have in each of our cells, which is about 20 to 25,000. And you can look again at the expression of all of them and see what pattern falls out. So it allows a much bigger evaluation of, again, the whole genome essentially in those nodules. And you can find, again, a pattern or a signature. And through iterative training and testing, that has been the process that this company, Veracyte, has led forward with a product they call Afirma. It's a gene sequencing classifier. And the results come out for that test in kind of a binary fashion. In this case, either benign or suspicious. And it keeps getting better with each version. And finally, then you should know about the DNA-based tests. This was based first off of the awareness that there were certain genes that appeared to be the cause of many thyroid cancers, most notably in genes called BRAF, you see on the left, and RAS on the right. And then some translocations or splitting together of genes in what we call RET-PTC or Pax8-PPAR gamma. And the company that has taken this forward has been CBL Path, and they work with a test that's referred to as ThyroSeq. It too has undergone iterations to keep improving. So we talk about ThyroSeq V1, V2, V3. And what you'll see is that as they improve, they use other molecular processes to improve, not just single gene mutation, but also copy number analysis. These are kind of genomic terms, and most notably RNA expression in that last version 3, which is similar a little bit to what the RNA-based test was doing as well, the Afirma. So the field has really rapidly evolved, and I would argue that we have moved over a decade or so from discovery to analytic testing to some clinical validation, but now we're in this area of clinical utility, and I'll explain all of this a little bit. Clinical utility implies a real large data as to how is the test playing out in the diverse real world that doctors practice in, that we all care for in, because we want to trust the test and see its impact on clinical practice and on a specific population. You may ask yourself, well, I've long heard that clinical validation is the most important, and indeed it's very important, but what I will argue to you is that we have made it through an era of high quality clinical validation, and that has been very important. It's been necessary, and there are now at least 2, I think, leading good tests. But the reason I say we've moved beyond this is even though each of the tests has had a blinded trial, as I'll show you, there's been no multi-center blinded head-to-head trials. So the ability for one test to clearly be tested against the other has not occurred. And so the way we're figuring out which we think are the best tests is using that clinical utility data. So I'm going to tell you the story a little bit here so you understand the background, which is how molecular tests initially kind of evolved as it relates to thyroid indeterminate cytology. About a decade ago, 2010, 2011, we saw the publication of a series of initial studies that were proof of concept. They really began to show you could use molecular analysis to improve care. And these were 4 of those initial studies. I highlighted, though, in kind of red here that there were a lot of kind of concerns that some of us had, that there were either small numbers or there were selected populations or things where we really saw the power but just didn't want to over assume that the data here in 2010 was exactly how it would play out in the real world. And that's exactly the hypothesis that we saw, that this was powerful, but it may not have been the answers we needed. In fact, these are the data that came out initially from those trials. And when you look at what I'm saying here, NPV stands for negative predictive value, how well a benign result from that test predicts no cancer. The PPV is positive predictive value, how well does a positive result from that test predict cancer? And you begin to see, as I highlight in blue, the numbers almost looked perfect. They were really good. And most of us in medicine realize it's hard to expect a perfect test in the beginning because there's a lot of diversity in disease and illness and amongst patients. In fact, I'll jump forward here a little bit. The 2 leading tests that I'm going to talk about, one is the RNA-based Afirma test, and the other is the DNA-based ThyroSeq test. These were the initial data that were published. And just to show what I'm getting at, when you looked at their so-called phase 3 trials, their big blinded trials, you see the numbers are much different. And that's why you need these big so-called phase 3 equivalent trials. That's an FDA term that we use that implies blinded, prospective, multi-center trials. That's where you get the best data that we can then take towards our patients for care. So that's what entered us in. The FDA, as I mentioned, was very supportive of the need for those trials, but that's what entered us in then to kind of these phase 3 trials that have been ongoing now for the last few years. And I list for you now essentially so about 6 of them, 5 different products that have been done. And again, I would ask you then, when you look at them, and this is what we deal with on the medicine side, is, well, which one would you use? Which one is the best one? And what you notice here is they all are showing somewhat similar numbers. And that, I think, is very important for you to know as a patient, is how does your doctor then think through this? And you may first ask, well, why wouldn't you just use the one with the best negative predictive value? Because maybe 99 is better than 94. Well, it turns out, just as a consequence, the one there and the last one, the Rosetta's platform with the highest NPV, that one went bankrupt because the data simply weren't as validated as the others. And so I want to show you just a little bit in terms of limitations of how we interpret these numbers. These are the 2 leading products right now that I think you would find most clinicians are using, either the ThyroSeq V3 or the Afirma gene sequencing classifier. So why wouldn't you just choose the one that had the highest number for NPV? Well, you should know that malignancy is a complex entity to provide a final reading on. Sometimes it's clear-cut, sometimes a benign process is clear-cut. But as you can imagine, there's an evolution between a benign process growing into a cancerous process. And when our pathologists who are experts in the field go to look at these kind of gray areas, you get some disagreements. Some would say, well, it's almost malignant, but not quite. And others will say it's clearly across that threshold. And what I show you here is 2 very big studies that were done to look at that. When you took blinded pathologists and you asked them to label a specimen that came out of the thyroid as benign or malignant, how often did they disagree? And it was always these subtle areas. It wasn't for very high risk disease where there was disagreement. It was kind of the low risk area. But you see that there's some disagreement up to 7–9% of the time for these low risk lesions. Well, that is important because that defines a limit to how good your test can be. If the gold standard that the test is based upon already has some level of uncertainty, then the best you probably can do in any test for negative predictive value reliably is about 95%, and most of the tests were hitting that. You may ask the question, well, why don't you just use the one with the highest positive predictive value? And these are the numbers I show you. Well, it's because they're about the same. Moving forward here. And so they're very similar when you kind of, and this is where we struggle with a little bit of the lack of competitive or comparative trials. Sometimes we'll look for something called a benign call rate. That simply is if you took thousands of patients in your office who had this test, what is the actual percentage that get a benign reading? And again, it's being used a lot to think about the two leading tests. We look back at the so-called phase 3 trial, but then we also kind of dissect the data in detail, and then we look at real world use, and I would argue they're quite similar. And so I want to bring us to this point, which is when you think about molecular testing, I would say the last decade has been amazing. There's a lot of discovery that's happening. We also have understood the need for those phase 3 trials. And so then that brings us though to the complexity that we now have validated or done those phase 3 trials on many tests, but we don't have any head-to-head comparisons. That's where it gets complex. And so how do we make sense of that? And what do I do as a clinician? Well, I think one is we continue to look at what's new and novel. What is the most recent understanding of molecular testing and which test is using those platforms? And then I focus my attention on this clinical utility, a lot of data that's being published on real world use, and is it showing what we know? And I'll show you just a few final slides on that, make sure we have time here for questions. One thing is we hear a lot about Hürthle cell neoplasms. That's a type of cancer. And in fact, that has been a real recent discovery of the fact that the molecular pattern in those tumors is different. And two tests, the Afirma platform and the ThyroSeq platform, are able to analyze to this degree. So that's why these are the leading tests, among other reasons. And then I would also say we've come to realize that gene expression is probably one of the most important aspects to understanding this illness. And that's because we know that we're looking at pathways that cause some of these indeterminate results, inflammation, growth pathways. And the best way to look at a pathway is RNA expression. To me, that's what gives the Afirma platform a little bit of superiority. The other thing we've learned is that all mutations don't necessarily mean cancer. And this is a big topic in and of itself. A lot of data here on this slide, but what I'm showing you in the box is when they look at the amount of DNA that is mutated in a benign reading, a benign nodule, or a cancerous nodule, it's about the same. Now, this has led people to say, yes, but the mutations are different in cancerous versus benign nodule, and often they are. But one of the problems that we've been having recently, where there's a lot of ongoing work, relates to that gene that I called RAS. And I'm showing you, again, a lot of slides. I'm not expecting you to look into all of it, but rather this point that when we look closely at what a RAS positive mutation means in your indeterminate nodule, we realize it doesn't always mean cancer. And in fact, the bottom here of the slide is this big meta-analysis of many different studies. This was performed out of Johns Hopkins and Martha Zeiger's group. And you see that RAS mutations, RAS positive nodules, appeared to be benign about half the time. That's the reason why we don't want to get over-reliant that a mutation means cancer. It doesn't. And that's why I tend to be pulled more towards using those RNA-based tests, the Afirma test, because it looks at pathways that are abnormal. So I'm going to move forward here just with that idea that we've moved from discovery, we've moved into development, analytic testing, we've moved through clinical validation. That was really important. And now we're looking a lot at the importance of clinical utility. How do we think about this in the real world? So we're looking at performance in the real world. We're looking at long-term durability. There's a lot of data on this coming, but that's how your doctors are thinking about it. So I'm going to end and leave time for questions because I know there'll be quite a few, and I want to give Dr. Noel her 30 minutes here as well, which is we're doing a lot better because of the use of molecular diagnostics. And with thanks for your time and attention, and really to celebrate what ThyCa is doing for this community and for our illness in this disease state, I'm so appreciative to have the chance to speak to you. I want you to kind of come forth with these conclusions that the use of molecular testing is improving care. So I do think in many ways, many of you will use this to help you and your doctor will use it together, but it's complex. And I just scraped the surface of it on purpose. And we have a lot of high quality validation now on several tests, but I do think the Afirma, the Veracyte Afirma platform is leading. I also think the CBL ThyroSeq platform, which is out of the University of Pittsburgh, those are your two leading tests. We've understood that gene expression appears to be very important here to this process of determining benign versus malignant disease. We've understood how Hürthle cell neoplasms are different. That's a different group of tumor. We've also understood clearly that DNA mutations, when one is identified, does not always mean that something is cancerous. Those are core principles to keep in mind. Seeing how things play out in the real world is so important to us. There are certainly many questions left to answer. I'm going to stop there and say a quick thank you. I'm going to stop sharing my slides. I know I breezed through an awful lot for you in just 20 minutes or so, and I'm going to pull up my Q&A box and give us about 5 minutes to go through some Q&A while Dr. Noel tees up her talk here upcoming. So let me read some of them. Just give me 1 second as I'm looking through them. Is there a way to get tested for genes mutations? So one thing here is the question here mentioned, I'm a survivor of papillary thyroid cancer, and I'm wondering about these genes and mutations. So that's a really important question, because what I told you just now and where we're seeing the molecular testing used most, I think, efficiently and effectively is before we know if it's cancer. So you have a nodule, there's some suspicion or atypia, there's an indeterminate result, and we're using the molecular diagnostics to tell us, do you need that surgery? Do you have cancer, more or less, yes or no? And even then, it's still not perfect, it's just improving. The molecular diagnostics are improving our predictive ability. So it's a very different question to say, I have thyroid cancer and what mutation is causing it, and should I find out what mutation caused it? It turns out up till now, in general, there has not been a need to figure out what mutation causes the cancer, because we generally have a good suspicion based simply on the molecular, on the histology that comes out with the tumor. When they tell you you have cancer, the doctors, and you get a full histologic analysis, and that already, synergizes and tells us quite logically what is the likely mutation. Now, I think that will change with time. I do think we're going to get into understanding for everyone what molecular mutation your tumor is causing. But right now, it hasn't shown any benefit. It adds a cost. That's the reason we're not doing it on everyone. 1 or 2 more questions here, keeping myself on time. Let's see, can genetic testing be useful post-surgery for prediction of recurrence? That's where we're going with it, but the answer, as I just said, is not quite yet. What can patients do who have thyroid cancers and have had total thyroidectomy 11 years ago? Slides are no longer available. I think there, especially if there's disease that's moved elsewhere, is a decision with your doctor on cutting edge kind of treatment. Would there be any reason to have benefit in looking at a new piece of tissue if you don't have the slides from before? And the question you're getting at there is kind of where I said we're going. There are some select scenarios where understanding a mutation for really advanced disease or recurrent disease can give us a target to understand, this treatment may now be better than that treatment. So there's many steps involved in that. That was a short answer. I do want you to work one-on-one with your doctor, but that's how we're thinking about it. This is my last question, and then I'm going to move on. If molecular testing was done on a sample several years ago, is it worth reassessing for new mutations or new things? I think generally not, because most of the time we're going to use that analysis for determining care steps moving forward in that moment. So there's very little benefit typically in going back several years. Usually we're going to kind of reanalyze fresh based on what we know in 2021 and not go and reanalyze as much from a few years back. So I know many questions. I know Gary's going to try and put these together, as will our hosts here, so that we can do our best to at least have some sort of compilation down the line to answer all of your questions. But for the sake of time, I am going to now pass the podium over to Dr. Noel and enjoy the rest of the symposium. Thank you very much, everyone.
Thanks, Dr. Alexander. All right. Hi, everyone, and thank you so much for tuning into this session. And thank you, Jeff, for the kind introduction in the beginning. I'm Julia Noel. I'm one of the head and neck surgeons at Stanford. My practice specializes in surgery of the thyroid and parathyroid glands. And I'm very excited to talk to you about something that's near and dear to my heart and also really indispensable to my practice. And that's the role of ultrasound, specifically in lymph node evaluation and how that pertains to surgical planning. And I know that many of you listening have had and will continue to have a number of ultrasounds as time goes on. And hopefully this also helps just somewhat demystify what you're seeing when you are getting those scans done. So when I was putting together this talk, I actually came across this timeline and just wanted to show it because I thought it was a really nice representation of how quickly this organization has become it's really an international landing site for patients, for caregivers, and then also for providers like myself who are trying to better support their patients. So I am honored to celebrate a very fruitful 25 years with you today. So you'll be surprised to know that there are over 300 lymph nodes in the neck, and most of these are so small that we don't necessarily feel them on an exam, and often they're below the detection threshold on imaging as well. But for the ones that we can see, it's really important that we're scrutinizing those closely because we know that thyroid cancer, and especially papillary thyroid cancer, does tend to involve neck lymph nodes, and that can be in 20 to 50% of cases. And while you may also undergo a CT or an MRI as part of your workup, those are really complementary to ultrasound, which gives us a very granular detail of the internal characteristics of a lymph node that help us decide whether or not a biopsy should be performed, and then whether or not that lymph node should be incorporated into a surgery. And the reason that ultrasound is so important is that it can often change what we think we need to do in surgery. And some studies have shown that this is the case in 20 to 40% of cases where finding on a preoperative ultrasound may change the extent, may change the approach of surgery. And so that's why this kind of comprehensive evaluation is really important. Lymph node mapping, you may have heard of. It's sort of a general term for just the close inspection and then the documentation of lymph nodes in the neck in the context of a thyroid cancer diagnosis. And if we do see suspicious lymph nodes during this exam, ultrasound offers us guidance for performing a fine needle biopsy, which we'll talk about a bit toward the end of this talk as well. And depending on the surgeon and the institution, the end result of this kind of evaluation might be the kind of graphic that you see here, where you can see that each lymph node has been labeled relative to the thyroid and the important structures in the neck. And so the surgeon is able to sort of have a roadmap to surgery. This also may take the form of a written report with the same level of detail. But it guides what we call a compartmentally based dissection. And what compartmentally based dissection means is that we are not so much performing surgery to target those lymph nodes specifically, but to target all the lymph nodes that are in the same drainage pathways. So this is an example. You can see where we've removed the suspicious lymph nodes, but there's also a lot of extra tissue in there. And so what we've done is remove all of the lymph nodes that share an area or a space in the neck with the suspicious ones, so that we are getting sort of a margin on our lymph nodes and taking care of all of the ones that share the same drainage pathways. And whenever we talk about identifying an abnormal structure, it always helps to know what a normal structure should look like. So we'll start with a few more normal characteristics on ultrasound. And size is a little bit tricky. It tends to be the most variable lymph node characteristic. And there is a lot of discrepancy in the literature about what size cutoff is appropriate for various locations. Generally speaking, the lymph nodes directly under the jaw are going to be a bit larger. And 20 millimeters is sort of an average cutoff, but certainly lymph nodes can exceed that size as well. And as you go a little bit further down in the neck, the size tends to decrease somewhat. So 10 to 15 millimeters is, again, sort of an average cutoff for that area. But again, the important take home here is that size alone shouldn't really be used to distinguish normal from abnormal. The next feature is shape, and a normal lymph node has sort of a long, flat, oblong shape. And the way that we assess this when we're doing ultrasound is that we're determining the ratio between the long axis and the short axis. And in general, we want this ratio to be 2 or more. So you can see in this ultrasound image here, here's your lymph node. And this measurement from here to here is 1.94 centimeters. This measurement from top to bottom is 0.87 centimeters. So in these images, this gives us a ratio of over 2 and is more correlative with a benign lymph node. When we look at the internal appearance of a lymph node, we are looking for something that sort of appears dark on the outside and then has a bright region or bright stripe inside of it, which is called the hilum. And the hilum is a fat-containing structure. That's why it appears bright in part. But it's also where the blood vessels enter the lymph node. So in the ultrasound image on the left here, you have 2 lymph nodes in the picture, here and here. And these blue arrows point to where the hilum is. And that hilum looks a little bit different than the ultrasound picture that you see on the right here, where the blue arrow points to more of a stripe structure that is the hilum in that figure. So it's a little bit different from patient to patient and also by area of the neck, but that's sort of the general morphology that we're looking for. And along with the hilum comes the blood supply. So to confirm that what we think we're seeing is really the hilum, we can use a tool on the ultrasound called Doppler, and Doppler will represent where the blood flow is within the lymph node. And so you can see in the left picture here, this blue arrow again is pointing to the hilum. And then as we move to the right picture, I know it's a little bit subtle and these orange areas represent other larger blood vessels, but you can see these 2 small dots of blood vessel inside the hilum there, which confirms, again, normal morphology of the lymph node. And normal is relative. So there's a lot of variability in lymph node appearance. And there are a number of non-cancerous conditions that will alter how many lymph nodes we see and how they look on ultrasound. Some of these include age. So in general, younger patients tend to have larger, more prominent lymph nodes. If you've been sick recently, if you've had a cold or a flu, if you get bad allergies, even if you've had dental work, if you haven't had a filling or a root canal, your lymph nodes might be a little bit larger than they would ordinarily. So this is just to sort of bring home the point that there's no one feature really that defines normal, and all of these characteristics we just discussed have to be interpreted in context with one another and then also with the patient. So now that we have this frame of reference, let's talk a little bit about what abnormal lymph nodes look like. And let's start back with shape. So we talked about how benign lymph nodes tend to be twice as long as they are wide. And so the opposite of is true in the examples here, which are suspicious lymph nodes. You can see these lymph nodes are more rounded in shape, which suggests that there may be tissue growing inside of them that is now expanding the borders of the lymph node. And unlike the nice, smooth, and more well-defined borders of the lymph nodes we saw earlier, suspicious lymph nodes might have irregular borders or appear uneven at the edges. So in this example on the left, you see how this node has a little bit of a scalloped appearance on the outside. And this lymph node on the right is also a little scalloped and has a tiny protrusion coming out of the side of it here. And now back to the hilum. This one can be a little bit tricky, and not seeing a hilum doesn't necessarily mean that the lymph node is suspicious. It might just be too small for us to see the hilum, or we might not be holding the probe at quite the right angle to catch it. So that's why I mentioned earlier, it's really important to interpret all of these characteristics in context with one another. But the difference maker here is the blood supply. So like we talked about previously, a normal blood flow comes into the lymph node in the hilum. But in this example here, you see in the right photo, the blood supply is actually going around the outside of the lymph node. And so this is a tip-off that this node has been overtaken by a process that is now replacing the hilum and is growing its own blood supply. Calcifications are something relatively specific to thyroid cancer, and we see them most often in papillary thyroid cancer. So we often see them in the primary tumors in the thyroid itself, but calcifications generally appear bright white on ultrasound, and they often create a little bit of a shadowing effect behind them, which is what the smaller white arrows are showing in this picture on the right. The calcifications in this image are a little bit larger, so these are called macro calcifications, whereas the smaller, more dot-like images are called micro calcifications. So another classic finding in papillary thyroid cancer are cystic lymph nodes, and these are fluid-filled. And this happens because of a combination of necrosis within the lymph node, meaning cell death from outgrowing the blood supply, and also from the production of a sticky fluid that's specific to the thyroid that's called colloid. So the black parts of these lymph nodes are the fluid-containing parts. Okay, so now let's move on to the ultrasound sequence itself and what we mean when we say a comprehensive evaluation. And every ultrasonographer has their own sequence and preference, but in general, after looking at the thyroid gland, we next look at the lymph nodes around the thyroid. And this area is called the central neck. This also gives us an opportunity to look at the voice box and try to assess vocal cord function. We can then move to the lateral neck, where we evaluate the lymph nodes from the jaw all the way down to the collarbone. And we'll talk about these compartments in a few subsequent slides as well. And most of the scanning will be done with the probe of the ultrasound horizontal to the neck. We can also turn it 90 degrees vertically to get a little bit of a closer look in that third angle. This shows the lymph nodes of the central neck compartment. So these are the lymph nodes that are lying between the two carotid arteries and from the larynx or the voice box all the way down to the collarbones or the sternal notch. And these are most likely to be affected by thyroid cancer just because of their proximity to the thyroid gland. So I'm going to show you a video here, and hopefully this works. So this will give you sort of an ultrasound view of scanning the central neck with the thyroid in place. So we'll go ahead and start this here. Oh, let's see. Shoot, I think my video may not be playing. Let's try. All right. Let me try the next slide and see if the video will play. Okay. That's good. So this will actually give you very much the same view, but we're starting with the, no, excuse me, shoot. We're starting with the thyroid gland in the middle here, trachea and larynx. And then this gives you actually a nice view of the vocal cords. So back of the vocal cords are here and here, and you can see how they move symmetrically together and then relax as the patient is holding their breath, breathing, talking, etc. And this is going all the way up to the tongue. This is important because, you know, in reality, level 6 does actually go up to just underneath the tongue base. So it's important that we're looking at the entire central neck here. And then I know it's a little bit of a long video, so in the interest of time, we'll move on to the next slide here. So this gives you a look on one side of the thyroid gland. Oh, shoot. And I'm sorry, my videos are only working intermittently, so I will play the ones that are working here. And let's try this one. No, not that one either. Okay, there we go. So right now we're looking at the left side of the neck. Carotid artery is here, trachea is here, thyroid is here, esophagus is down here. And so although this is a relatively normal sweep, this is the area that we're looking at really below the thyroid and deep to the thyroid as we're scanning. So moving on a little bit to the lateral neck, this is sort of the next step in lymph node metastases when there's been spread of cancer just, you know, beyond just the thyroid gland and the surrounding lymph nodes. And for thyroid cancer specifically, the areas that are most commonly affected are those indicated by the blue arrows. So these, you may have heard these terms before just during evaluation or even prior to a surgery, but these are called levels 2, 3, and 4. So 2 up by the jaw, 3 sort of in the middle, and then 4 down by the collarbone here. Level 1 includes the lymph nodes around the salivary glands. These are uncommonly affected in thyroid cancer. And then level 5 is back here, you know, almost toward the back of your neck, toward the trapezius muscle, which can sometimes be involved in thyroid cancer, and we may need to include in the surgery as well. So I'm going to give you, hopefully, an image of sweeping through the side of the neck on the right side. Let's see if this will cooperate. It seems like if I advance my slides and then go back, sometimes it works. Oh, okay, how about this one? All right. So this one now shows you a sweep through the lateral neck with the sternocleidomastoid muscle up here, the carotid artery here, the jugular vein here. And so hopefully you can appreciate as we're scrolling through that we're seeing some abnormal lymph nodes that don't have a hilum, that don't have that nice dark cortex, that are enlarged and look a little bit rounded. I'll play that for you one more time. So for instance, this is our first sort of suspect lymph node. There's one with calcifications inside of it. And then as you go down, you can sort of see these popping in and out of your screen as we scroll past. Okay, so after we've done our thorough neck ultrasound, we might decide that a biopsy is indicated to interrogate a suspicious lymph node. And very small lymph nodes are hard to see and also difficult to accurately target with a biopsy. So the lower limit really to do a fine needle aspiration is about 8 millimeters for the central neck lymph nodes and about 10 millimeters for the lateral neck lymph nodes. And ultrasound guidance should certainly be used. It will drastically increase the success and the accuracy of doing this kind of biopsy. And one very helpful maneuver specifically in thyroid cancer is actually to rinse the needle and send that fluid for what's called thyroglobulin. And thyroglobulin, you may recognize that name from having blood tests for thyroglobulin. before and after surgery. And that is a protein that's made by thyroid cells. And we know that it doesn't then belong in a neck lymph node. And so identifying this kind of tissue in a lymph node will help us determine that indeed, thyroid cells and probably thyroid cancer cells have spread to that lymph node, even if the cytology or the actual cells don't give us a conclusive diagnosis. And you can imagine this happens not infrequently, especially in those papillary thyroid cancer nodes that have a lot of cystic change, that we may get a lot of fluid from those biopsies, but there's actually not a lot of solid material from which we can get cells to identify the type of cancer. So especially in this case, the thyroglobulin washout can be really useful. For medullary thyroid cancer, calcitonin can also be done as a washout from the needle rinse. So that is a really useful sort of adjunct measure in fine needle biopsies. And so I'll end with some take-home thoughts, and then we'll take questions. I can't emphasize enough the importance of having a really thorough, comprehensive ultrasound prior to surgery, especially because we know that it does often influence either how much surgery needs to be done or the approach that needs to be taken during surgery. And it is complementary to the other types of imaging like CT or MRI, but really does in and of itself give us the best detail of lymph node morphology, and can also help facilitate biopsies if biopsies need to be done. And this kind of evaluation is really the key to having a complete and successful surgery. So I will end there. I apologize for a couple of those videos not working. And I'm just going to bring up the chat or the Q&A box, excuse me, and see if I can hopefully answer some questions. But okay.
So let me just say, Dr. Noel, officially the meeting ends at 2:15, about 6 minutes from now, but we can actually go over by 10 minutes if you and Dr. Alexander are willing to answer a few more questions beyond 2:15. That would work for about 10 minutes.
Okay.
But I realize you may be busy and have other.
No, that sounds good to me. I'm happy to stick around. Okay, so let's see. I think Dr. Alexander addressed a lot of these already. So, from a molecular testing, is it difficult? So, let's see, I was informed that it's difficult to get good ultrasound imaging of the central compartment lymph nodes below and behind the thyroid. What are your thoughts on this? Does it depend on the skill of the clinician? Is there a specific quality or grade of ultrasound that makes a difference? These are all great questions, and I'd say that it's a little bit contingent on whether or not the thyroid is present. So it's much more difficult to evaluate central neck lymph nodes with the thyroid there. The thyroid can sort of compress lymph nodes that are behind it, and then for the lymph nodes that are below it, now we're sort of getting into the, what's called the mediastinum, or the upper part of the chest, where the tissue planes just tend to get slightly more blurry in general. So it's harder to do with the thyroid there. It's easier to do after thyroid surgery has been completed. And, any radiology suite will have a sufficiently powered ultrasound machine with a nice screen that can evaluate lymph node detail. The central neck lymph nodes do tend to be a little bit smaller, and so it can be difficult to make a call on normal versus abnormal. But, I think in general, easier done with the thyroid out. And skill of the clinician, I think it just depends. It just depends that you're seeing someone that's familiar with thyroid ultrasound. But radiology suites do have high-powered machines that have nice screens to be able to evaluate. So, and let's see. Next question: is it okay to wait and watch lymph nodes yearly that are not right? Recurrence 10 years apart, cancers in a lymph node. That's also a great question. So, and it depends a little bit on the cancer type, but in general, for the well-differentiated tumors, especially for the papillary thyroid cancers, the pace of growth is going to be very slow, and it depends on the size of the lymph node. It depends on the location relative to surrounding structures. So if the lymph node is small and it's not threatening any important structure immediately, then it's certainly not unreasonable to watch the pace of growth and decide whether or not a biopsy would be indicated. So I think the other thing is that once you have committed to a biopsy, that sort of means that you've committed to a surgery. If you have a positive result, you do need to be prepared to proceed with surgery if you're going to be proceeding with a biopsy. So I would say, in general, depends on size and location, but pace of growth is generally small. So it is a reasonable thing to wait. Okay. 6 millimeter lymph node watching in level 1B. 6 millimeters is quite small. For this level, we generally wouldn't recommend a biopsy under 10 millimeters. And I'll also say that 1B is one of those levels that's less commonly affected in thyroid cancer. So that can probably be watched for the time being. Why do some physicians do their own ultrasounds and others send you to the radiology lab? Is there a difference in quality? I think it depends on the surgeon and the institution. So, sort of the gold standard for having thyroid and neck ultrasound is to go to radiology. That's where the formal reports come from. I think a lot of endocrinologists and surgeons are incorporating this into their practice because there are some things that we might look for on ultrasound that are not necessarily that may not be in a radiology report that's specific to someone's anatomy, for example. So I think, for that reason, it just helps us, give us a little bit of a roadmap of your neck, so to speak. Post-thyroidectomy, how often do you recommend follow-up ultrasound? It depends a little bit about how your risk level was stratified in terms of risk of recurrence. And response to treatment, but in general, every 6 months is standard. And then if you are stable and if you've had an excellent response to therapy, that can be pushed out to annually. What does scar tissue look like compared to healthy nodes? It's a good question and can be hard to differentiate sometimes. So scar tissue often looks bright. It looks, the fibrosis tends to look sort of bright white on the ultrasound. It does tend to be avascular, not have much of a blood supply. And the shape is a little bit amorphous. And so that's why attention can sometimes be called to scar tissue on an ultrasound because it just doesn't have a very clean border. Let's see. Do you think ultrasound, this is a good one. Do you think ultrasound techniques are getting better with more advancement and catching more nodules? And the answer is yes. As we are getting better ultrasound machines and screens, we are catching more nodules. And I think, there's a balance of how much to worry and investigate these and, sort of how detail oriented to be. Because as our level of detection increases, that prompts us to want to do more in terms of investigation and intervention. So I think there there are certainly some physicians in the thyroid world that almost wish that our, that our sensitivity for detection could sort of stop at some level, so that we are not necessarily always having angst over very small nodules that are too small at that point in time to intervene on. Okay. So I'm happy to keep going. Should I keep going? Looks like there are a lot more questions.
Yep, I think you can keep going.
I think you're fine.
Okay.
They'll kick us off.
All right. Let's see. So there's a question about alcohol ablation for lateral neck lymph nodes. And it's a good question. Alcohol ablation is sort of reserved for the situation in which someone has already had surgery one or multiple times in the compartment in which that new lymph node has popped up. And, the surgeon may be hesitant to re-enter that space just for fear of, causing more harm than doing good. And so alcohol ablation can be done for smaller lesions, typically less than 1.5 or 2 centimeters, so long as they're not close to really important structures. We don't have a lot of control over where the alcohol goes after we inject it. The vast majority of it will stay in the node, but some will probably diffuse out. And so we want to make sure that if a little bit does diffuse out, that we're not going to be affecting any important nearby structures. Let's see. I think more additional questions just about ultrasound technology. And yes, it is true, ultrasound technology is catching more nodules, it's catching nodules earlier. And so again, there is sort of this, there is at some point has to be kind of this crossover between sensitivity of detection and risk versus benefit of intervention. And so I think interpretation of ultrasound always needs to be taken in that context with considering, if we are to intervene, then are we helping more than we are potentially hurting? And let's see, is it important to continue to travel to get ultrasounds done or done locally? I think that very much depends on sort of your thyroid cancer status and access to resources locally. I think if you have a very stable situation, you are far out from treatment, and nothing has been worrisome for some time, then it might at that point make sense to transition to a local follow-up if you feel comfortable. Is it common to have a fine needle biopsy, have a benign diagnosis, but then turn out to be malignant? It can happen. It's not common, but again, metastases within lymph nodes tend to start in the microscopic realm. So it is not uncommon to have a very small focus of thyroid cancer inside of a lymph node that just is not picked up on the needle biopsy. And so it's, again, not common, but possible. And, fortunately, the significance of these very small deposits is generally doesn't have a big impact on long-term outcome and survival. And so, this is a situation in which a lymph node could be followed if we're still sort of suspicious of it ultrasonographically, but the initial fine needle biopsy has been benign. So there's a question about tall cell variant, and let's see. Sounds like a pretty extensive surgery 2 times, and then now concerns over the non-operated side, it sounds like. Before committing to any surgery, I think it makes sense to do a biopsy to confirm that there is a recurrence there if there are lymph nodes that qualify for a biopsy. As you may know, tall cell tends to behave a little bit worse than the classic variant of papillary thyroid carcinoma. And so if there is confirmed disease and this is a side that has not yet been operated on, then it's certainly worth speaking to a surgeon about whether or not that would make sense to do. Yeah, so and then this is also a great question. So slow growth of papillary thyroid carcinoma, should microcarcinoma and lymph nodes not be a concern? Or does it prolong when the recurrence occurs? So the presence of microcarcinomas within lymph nodes is generally, we call it not clinically significant, not because it's not important to know about it. We call it not clinically significant because we know that it doesn't have a significant impact on long-term outcomes and also on long-term survival. So I know that it is, I think it's worrisome to think about the possibility of that, but in truth, that is probably something that may stay the same size for the duration of follow-up, or may grow so slowly that it never sort of reaches the threshold for intervention or even reaches the threshold for a biopsy. And so I think it is, again, there is sort of this sweet spot between doing a thorough evaluation, but also not, not becoming too concerned over the kind of very small abnormalities that may prompt a potentially unnecessary intervention.
Okay, I think at this time we can wrap up. It's 5:25. So thank you, everyone who is participating in this.